not do this movement and this movement and this movement and not know why. So this is the most important thing of this workshop. So, and to give systematic review of shoulder ultrasound or even any MSK ultrasound, we should divide each joint into compartments. For example, shoulder into anterior and posterior compartment, elbow into medial, lateral, anterior and posterior compartment. Why do that? It is systematic review in order not to miss any structure to examine it. So this is the most important thing. What's the another important thing is to know the muscle anatomy, origin, insertion, action, and nerve supply. Action is very important here, and nerve supply for pain management. So be confident, think out of box, not use movement without thinking why. Never use movement without thinking why. So after this workshop, every doctor, inshallah, will able to understand the anatomy, normal anatomy, and even pathology of the shoulder joint, and how to do injection properly. Now begin with shoulder anatomy, but I exit from this because I want to teach anatomy on 3D. Okay.
إذا تبين نطفي هذا الفلاش حطيت له واضح في مخالط شوي بس انتي بادي
With the anatomy of the shoulder joint. So, shoulder joint consists of 4 joints. 3 are synovial and 1 is not synovial, false joint. The largest and the biggest synovial joint in the shoulder, it is the glenohumeral joint, which is between the glenoid, which is a part of the scapula, and the humeral head. This glenoid is deepened because it contains fibrocartilage called labrum for stability of the shoulder joint. So this is the biggest and the largest joint in the shoulder joint. Another joint is between the sternum, should be here, and the clavicle. It is the sternoclavicular joint. Another joint is between the clavicle and the acromioclavicular joint. All these joints are synovial joints. The last joint, which is scapulothoracic joint, between the scapula, anterior surface of the scapula, and the thoracic cage in front of it. This is not a true synovial, it is false joint. This regarding the joints. Regarding the bone, we know that the shoulder joint consists of scapula, clavicle, and the humerus. So the scapula have 2 surfaces. Anterior surface is concave surface, and posterior surface, this posterior surface, contain spine, which divides the scapula into superior and inferior surface, suprascapular and infrascapular surface. The continuation of this spine is called acromion, which make a joint with the clavicle called acromioclavicular joint. Regarding the humerus contain of a humeral head. There is 2 important tubercle here in the examination of shoulder ultrasound. The medial tubercle is called laser tubercle, and the lateral tubercle is called greater tubercle. Between these 2 tubercles, there is a groove. This groove in which the long head of biceps tendon pass through this groove and contain ligament above this tendon called transverse humeral ligament to maintain long head of biceps in its location. Now go to the ligaments. So the most important ligament in the anterior compartment of the shoulder joint are, number 1, it is It is coracohumeral ligament. It is between the coracoid process and the humerus. This is very important. Why? Because the thickness of this ligament can cause impingement of subscapularis muscle. It is just above the subscapularis muscle. So the white structure, when doing ultrasound above the subscapularis muscle, this structure is called coracohumeral ligament. Any thickness of it more than 2 mm can cause subscapularis muscle impingement, and it is a part of pathology of a frozen shoulder. This is the first ligament. Another ligament is passed between the coracoid process and the clavicle, called coracoclavicular ligament. Coracoclavicular ligament. We have two parts, medial part and lateral part. The medial part is called conoid part, and the lateral part is called trapezoid part. The medial part is most important. Why? Because just above this ligament, the medial part of the coracoclavicular ligament, which is conoid part, there is lateral pectoral nerve, which is the nerve supply to the anterior shoulder joint. So when we do ablation of shoulder joint and pain management, we do ablation of this nerve. By examination of this nerve, then can put the needle with implant technique and do ablation by radiofrequency ablation equipment. Another important ligament here is between the clavicle and the acromion. It is called acromioclavicular ligament. This ligament is also important. Most patients clinically come with tenderness at this region. When do exam, clinically, there is a tenderness over this region. So doing examination by ultrasound, nothing by ultrasound, but we can treat it clinically, even if there is nothing by ultrasound. By injection of PRP, which is platelet-rich plasma, or steroid injection at this site, at the acromioclavicular ligament. Another important ligament which comes from the glenoid to the humerus, humeral head. These are glenohumeral ligament. We have three parts of a glenohumeral ligament: superior, middle, and inferior. Unfortunately, by ultrasound, we can't see the superior and middle glenohumeral ligament. We can only see the inferior glenohumeral ligament. How can we see it? By putting the probe in the axilla. So of this thickened, which is the inferior part of the glenohumeral ligament, inferior in the axilla, it is also a part of frozen shoulder. This is explain the labrum, how the glenoid is deepened by joint capsule, and labrum. This is covered by joint capsule from outside. Now we go to the muscle. So we divide the shoulder into anterior and posterior compartment. The most and the largest muscle in the chest, and it is contribute also to the shoulder joint, it is the pectoralis major muscle. Why we should understand the pectoralis major muscle? Because it gets insertion into the shaft of the humerus surrounding the long head of biceps. So when examined by ultrasound, we see the long head of biceps. There is muscle, myotendinous junction surrounding this tendon of long head of biceps in the shaft of the humerus. It is the largest muscle of the thoracic cage. It is pectoralis major muscle. Below it, which comes from the medial part of the coracoid process, is pectoralis minor muscle. We can see just tendon by ultrasound by putting the probe on the coracoid process and see from the medial part it will come. Also, there is most important long head tendon of biceps, which comes from supraglenoid part and pass. It is intracapsular muscle, so it is passed within the bicipital groove between the laser and the greater tubercle. Above it, there is a transverse humeral ligament to maintain its location. This is the long head of biceps muscle. From the lateral part of the coracoid process, we have two muscles. Anterior muscle is the coracobrachialis, and below it is the short head of biceps muscle. This is how explain pectoralis minor muscle come. And and the coracobrachialis, short head of biceps with coracobrachialis. So, as we said, divide the shoulder into glenohumeral, acromioclavicular, sternoclavicular, and the scapulothoracic pseudo joint. All are synovial except the scapulothoracic, which is not a true joint. So now, how to do ultrasound? By doing ultrasound, there is something called home page. What is home page? It is something to go to examine it, and when we forget or lose the structure, you can return back again to the home page. So it is as a landmark to you. You can return back to it and begin again when you lose some structure. So what is home page? Home page is by beginning of examination of the shoulder by putting the hand in neutral position. It is just below the bicipital groove. Put the probe transverse here, and you can see this home page, which consists of the most and the largest anterior muscles, which is the deltoid muscle. It is the largest muscle in the shoulder that maintain the anterior and lateral and the posterior compartment of the shoulder. So every muscle that appears in the shoulder when examination by ultrasound, it is called deltoid muscle. It is the bulkiest muscle. Then you can see also by this picture. This is the home page. So this is the deltoid muscle. Okay, this is the position of the probe, just under the bicipital groove. The bulkiest muscle here is the deltoid muscle. You can see also the long head of biceps start to appear. This muscle that comes like a fan surrounding this long head of biceps is called pectoralis major muscle. So why we should understand pectoralis major? Because it gets insertion into the shaft of the humerus surrounding the long head of the biceps muscle. So by beginning from this, you can see the deltoid, long head of biceps, then continue upward till reaching the bicipital groove. What you see by the bicipital groove, you can see the long head of biceps in transverse or axial section. Then what you do, then open on the long head of biceps and you can see it longitudinally. Another important muscle in the anterior compartment is by the probe slightly medial to see the coracoid process. Just below the coracoid process, the first rotator cuff muscle comes, which is subscapularis muscle. Subscapularis, it is the only muscle that comes from the anterior compartment and the only muscle that is inserted into the lesser tubercle of the humerus. All are inserted in the greater tubercle. Only the subscapularis muscle come to insert it into the lesser tubercle. Rotator cuff consists of 4 muscles. These are subscapularis, teres minor, infraspinatus, and supraspinatus muscle. So divide notes to examine the joints, ligaments, bursa, and nerves. This is the home page, what I said. Okay, so continue upward until reach the bicipital groove. This is the bicipital groove through which the biceps tendon will become. This structure, white line just above the biceps tendon, is a transverse humeral ligament. If you open here color Doppler, you can see small bubble pulsating here. This is the humeral circumflex artery. Circumflex humeral artery. This is how to examine the long head of biceps by longitudinal scan. Okay, we said about subscapularis muscle. It is the only muscle, okay, this subscapularis muscle. It is the only muscle that will be inserted into the lesser tubercle. Okay, how to examine now the subscapularis muscle? This is the most important. Previously, we just do this and this. But why? Any doctor can say why? Why do this movement and this movement for examination of subscapularis muscle? Okay. Subscapularis muscle, its action is internal rotation. That's the important action, internal rotation. So when I examine this muscle, I should do movement against its normal movement to make it more stretched. So that's why I do external rotation to make it more stretched. Its action is internal rotation. I do external rotation. So now I understand what's its action and why I do this movement. I do this movement against its normal action. So this is the examination, dynamic exam of subscapularis muscle, and it is also called the impingement test. So now, this is the laser tubercle. From here should be appear the coracoid process. So subscapularis muscle comes from under the subscapularis muscle to get inserted into the laser tuberosity. And this is the movement how to do examination of the subscapularis muscle. This is deltoid, skin, fat, facial, deltoid, and subscapularis muscle. Okay. Now, are we complete the anterior compartment? I say no.
Ligaments.
We have in the
Muscles.
anterior compartment, we have muscles, we have ligaments, we have bones. So we should complete examination of the anterior compartment. I said should examine bone, so I examine the humeral head, I examine the coracoid process, then examine the muscle, which is deltoid, long head of biceps, subscapularis muscle, pectoralis major muscle. Complete that. After that, we go to examine the ligament. So what are important ligament here? Important ligament just above, if I see in the previous picture, just above this. Just above the subscapularis muscle. This white line that passes from the coracoid process to the laser tubercle. This is the coracohumeral ligament. This is most important to examine it and to measure its thickness. It should be not more than 2 mm. But actually, it is important to see its structure, not to measure it by millim. Because if there is abnormality, there will be hypoechogenicity, there will be thickness, there will be fluid collection. So not judge only on measurement. If it is 3 millim, some doctors say that is 3 millim. Oh, it is thickened. No. You should see the structure of it. It is thickened. It is contain hypoechogenicity. It's contain anything. So it's abnormal. So this is important ligament. What are other important ligament? Other important ligament is the coracoclavicular ligament. As we said, that coracoclavicular ligament consists of medial and lateral part. The medial part called conoid part, and the lateral part called trapezoid part. T with T, lateral trapezoid. The medial part is important because the lateral pectoral nerve comes above of it, and we can see on demonstration also. Another ligament is the acromioclavicular ligament. Another ligament is the coracoacromial ligament. Till now, we complete the anterior compartment. Now go to the back of shoulder. This is all the anterior compartment. Now go to the back. So what are the important structures in the back of the shoulder joint? We have the remnant of the rotator cuff muscles, which are supraspinatus, infraspinatus, and teres minor muscle. How to examine supraspinatus and from where it comes? It comes from the suprascapular fossa. This is its origin and get inserted into we have in the greater tubercle. If we return back, but this is just an anterior posterior. This anterior surface, not posterior. Okay, we have in the posterior surface of the humerus, we have 3 facets on the posterior surface of the greater tuberosity: superior, middle, and inferior facet. Superior for supraspinatus, middle for infraspinatus, and inferior for teres minor muscle. So supraspinatus muscle comes from supraspinous fossa, from above the spine of the scapula, to get inserted into the superior facet of the posterior surface of the greater tuberosity of the humerus. How to examine it? We begin exam, palpate the scapula, spine of the scapula, and put the probe transversely above the spine of the scapula, and begin from medial to lateral. At the medial part, it is like fish appearance. It is with a small thickness. They continue lateral, lateral, lateral until its thickness will be increased. Okay, now we do this exam of supraspinatus muscle. But how to do dynamic exam of this muscle? Supraspinatus comes at the lateral part at the greater tuberosity, back surface. So its action What its action? Its action is abduction. Abduction. It is in the outer part. So how to do examination of it properly? By do action against its normal action. Its action abduction. So I do adduction. Adduction of shoulder by doing like this. So why I do adduction? Why I do this movement? I not keep this movement. I understand this movement because its action is abduction. I do against its normal action. It's adduction. So I do this movement and continue to examine until reaching the superior facet of the posterior surface of the greater tuberosity of the humerus. This structure is called footprint. Like footprint. This supraspinatus muscle, footprint. Between this supraspinatus muscle and the deltoid muscle, there is a small black line. This is called subacromion subdeltoid bursa. Seriously, it is subdeltoid, not subacromion. Subacromion comes from below the acromion, but is in continuous with this, so it's called subacromion subdeltoid bursa. It should contain just a few million of a fluid. If it is thickened or contain much amount of a fluid, it is called bursitis. So its action is abduction and do examination by doing against its normal action by doing adduction. This movement. This is also supraspinatus muscle. I say I begin from here, then continue until reach the footprint of the greater tuberosity. Now, how to examine the infraspinatus and teres minor. We say that supraspinatus comes from suprascapular fossa. Now, palpate the scapula and examine below the scapula. Also continue from medial to lateral. From medial also it is fish-like appearance and then increase its thickness laterally. How to do dynamic movement of this muscle? What's the action of infraspinatus? It is also comes in the middle facet of the posterior surface of the greater tuberosity. So it is outside. Its action is external rotation. External rotation. How to do examine of it? By doing movement against its normal action. Its action is external rotation, so I do internal rotation. Internal rotation. Now I understand, not keep these steps. It is not like steps.
Okay.
We should understand why doing this movement. Okay, so continue to examine this the infraspinatus muscle until reaching the greater tuberosity of the humerus. And just below it, by doing funny tilting downward, you can see the teres minor muscle. And below it is the triceps muscle. This is important picture because it is the approach, anterior approach for injection of the shoulder joint. When I examine the subscapularis muscle at the same side, when I see the coracoid process on subscapularis muscle, I just do fanning upward to see the supraspinatus as well, and long head of biceps in between. So the space between subscapularis muscle, supraspinatus muscle, and the biceps tendon in the center, the space, black space, is called the rotator cuff interval. So this is important. Why? Because we can do injection at this site. We can produce your needle and inject. For example, even contrast media. Sometimes when doing arthrography, you can also inject contrast here at the same site. You can inject PRP here. You can inject monovisc. Monovisc is hyaluronic acid to increase lubricance of the shoulder joint and decrease the osteoarthritis changes. So this is important picture. Okay, when we examine the supraspinatus muscle and continue from medial to lateral, there will be a defect at superior surface of this muscle. What this defect called? This called suprascapular notch. Suprascapular notch. It contains suprascapular nerve, suprascapular artery. So this is important. But we can do ablation here. This is the spinal glenoid. This is the suprascapular notch. In the suprascapular notch, where the supraspinatus come and this defect below it, we can't do ablation here. Why? Because the suprascapular nerve at this side contain motor and sensory supply. So if we do ablation of this nerve, ablation means we do neurolysis, third-degree neurolysis. So we lose the motor function of the muscles. Suprascapular nerve supply the supraspinatus and infraspinatus muscle. So we lose the motor function. So we can't do ablation at this side. What is other side for doing ablation? When I continue examination the infraspinatus muscle from medial to lateral till reaching the glenoid, there will be a defect just in front of it. This defect contain a blood vessel and nerve. This is called suprascapular nerve, and this is spinoglenoid notch. Defect here is suprascapular notch. Defect here is spinoglenoid notch. At this site, we can do ablation because it contains only sensory branch of articular branch of suprascapular nerve. So anterior shoulder joint is supplied by the lateral pectoral nerve, posterior by suprascapular nerve, and lateral by axillary nerve. This is the bursa, what I said. When we see the footprint of supraspinatus muscle and deltoid above it, we see there is a black line between them. This is called bursa. Sometimes there will be bursitis. So this picture indicates that there will be needle pass into bursa to inject PRP or steroid. This is the picture of rotator cuff interval. As we said, it is the most important for anterior approach of articular injection. We speak about the ligament. We say that the most important ligament is the coracohumeral ligament, which pass above the subscapularis muscle, and acromioclavicular ligament. It is also important because just below it pass the supraspinatus muscle. So if it is thickened, it can cause supraspinatus impingement. This is the acromioclavicular joint. How to do exam? By putting the probe transversely between the acromion and the clavicle. This is acromioclavicular joint. We can do also injection here by steroid or PRP, but should not pass the needle more than 2 mm here. Why? Because the supraspinatus muscle comes just below this side in order not to make tear or rupture of this muscle. Steroid is very dangerous. When you put a steroid inside muscle, it can cause rupture of muscle. Now some pathological terms. What means by tenosynovitis? Every tendon and muscle is surrounded by synovial membrane, synovial sheath, contain just a few ml of fluid. We can see by ultrasound. So if this synovial sheath surrounding the muscle or tendon is thickened and become hypoechoic, and when we open power Doppler or color Doppler, we show increased vascularity. This is called tenosynovitis. It is at the muscle, at the tendon, surrounding the muscle and tendon, because of thickening of synovial sheath, in which fluid accumulated, debris accumulated, power Doppler increase. Can be treated either conservative by anti-inflammatory drugs, or can be treated by steroid injection, interventional steroid injection. What is enthesitis? Enthesitis means that there will be inflammation at the tendon insertion to the bone. For example, Achilles tendon, which gets inserted into the calcaneum. This is most common site for enthesitis. So you can also treat it by steroid injection or PRP. So what is enthesitis? It is inflammation at the insertion of the tendon. Muscular tear, we have two types of muscular tear, either partial or complete. You can see longitudinal linear defect. If it is partial, only small substance of linear lack of anechogenicity can be seen within the substance of muscle, and this can be treated conservative. And complete, this is when there will be defect, and not only defect, but also there will be retraction of muscle to other sides. Frozen shoulder, it is a clinical term. In pain management, it is a clinical term. when the patient comes with limitation of movement of more than 50%. So I do a range of movement to the patient. I say to him, do flexion, do abduction, do internal rotation, do external, all the action of the shoulder joint can be done. If there will be limitation of movement, it will be diagnosed as a frozen shoulder. But what can you see by ultrasound? The most important thing is the coracohumeral ligament thickening. Coracohumeral ligament thickening, which comes just above the subscapularis muscle, as we said. Another part is the inferior glenohumeral joint. Most important to be lost in the frozen shoulder is external rotation, which is against action of subscapularis muscle. So approximately 60 to 70% of frozen shoulder have subscapularis muscle impingement. Now, how to do injection? Whether it is normal injection or whether to do ablation by radiofrequency. If we do, like for example, steroid or PRP or local anesthetic, for example, we have to approach either in a plain technique or out of a plain technique. But we prefer in pain management in a plain technique for many reasons. Number one, that we can see the whole length of the needle when it passes in order to avoid vascular injury, muscle tear, nerve injury, and else. So how to do in a plain technique? I put the probe like this, transverse or longitudinal, no problem. I put the needle parallel to the ultrasound probe with acute angle, less than 45 degrees. Like for this, the needle pass parallel to ultrasound probe with approximately 45 to less than 45. If make the angle more than 45, we lose the tip of the needle. So better to use the needle in a plain technique with acute angle less than 45 degree. This is the in a plain technique. Another technique is out of a plain technique by putting the needle perpendicular to ultrasound probe. But this is not preferred. You can do this by FNA or the thyroid if it is superficial nodule. But in pain management, we can't do this. So we say how to inject the shoulder joint if it is, for example, severe osteoarthritis, and there is severe limitation of movement, osteophyte, and the patient can't move his shoulder. So I need to hydrodilatations of his shoulder to make more movement for his muscles, to make more space for the joint. So injection of monovisc. What is monovisc? Monovisc is hyaluronic acid, as we said. It is commercial type of hyaluronic acid can be put at the shoulder joint. So we have two approach. The anterior approach is at the rotator cuff interval. As we said when we examine subscapularis muscle, there will be a space, black space, surrounding this rotator cuff. This is called rotator cuff interval. We can do injection here. And even for every radiologist, you can do arthrogram by putting contrast and do CT or MRI. This is the anterior approach. The needle should be used as a 22 gauge needle because it has approximately 10 centimeter length. Posterior approach, when we examine the infraspinatus muscle and continue lateral, we reach the glenoid of the humerus. Just in front of the glenoid, there will be fibrocartilage of labrum. We can do injection here, just below the infraspinatus muscle and above the hyaline cartilage of the glenoid. We should not touch the hyaline cartilage of the glenoid because it is very painful. We can do injection here. So injection can be done by platelet-rich plasma because it contains growth factors, regenerative elements, can be used in OA changes, even rheumatoid arthritis, any inflammation, you can put it because it contains regenerative factor and also contains some anti-inflammatory components. And also by steroid, give 2 to 5 ml, but avoid injection of steroid within the muscle because it can cause muscle rupture. And hyaluronic acid. We say nerve supply, anterior compartment of the shoulder is supplied by the lateral pectoral nerve, and the posterior by the suprascapular nerve, and the lateral by the axillary nerve. We have a new technology in nerve, how to see the nerve. Previously, it is very difficult to see the nerve. Sometimes we can do injection, we can't see the nerve just beside it by doing the stimulation, because we have in the radio frequency equipment, we have sensory stimuli and motor stimuli. So we give hertz, for example, 50 megahertz, and do stimulation. So the patient muscle will be vibrating. So that's okay. You are in the nerve, you are beside the nerve. But now there is a technology how to identify the nerve by putting a rectangle in the equipment, rectangle which is yellow in color, around the nerve. Large nerve, not a small nerve. For example, median nerve or ulnar nerve. This is median nerve, which appears in the picture. This is called nerve track technology. This is the radio frequency ablation equipment. Its principle is by doing a neurolysis, third degree neurolysis. Why we don't do fourth or fifth degree neurolysis? Third degree neurolysis, the nerve can be regenerated again. But in the fourth or fifth degree, the nerve can't be regenerated again and can cause pain more severe than the previous pain. This is called dedifferentiation pain. So we should do third degree neurolysis. It should be with 70 degree, 60 degree for 2, 1, then repeat again for 1 minute, then repeat again for 1 minute. If it is more, can cause severe pain. This actually, nowadays, it replaced the shoulder replacement, even knee replacement. For those especially old age patients, women or men, can go with severe OA grade 4, and the doctor of orthopedics say that should be doing replacement, whether shoulder or knee. This technique, by neurolysis of the nerve, can avoid doing replacement surgery by neurolysis of this nerve, so no pain. Pain relief is approximately 80 to 90 degrees for 1.5 to 2 years. And we have several types of radio frequency. We have conventional type, we have pulse type, we have monopolar and bipolar type. We mean by conventional, it is continuous temperature. Pulse, it is pulse temperature. It is neurolysis and then not, neurolysis and then not. So there are available many types, but in shoulder we use conventional type. So our home message today, we are all radiologists.
Yeah.
So we should examine better than anesthetists, better than orthopedics, better than others who are not specific in ultrasound. So keep attention, keep always examination of the MSK, whether shoulder, whether knee. You can do examination every day on your patients, even if it is not indicated for shoulder or for knee. You can do also examination on your colleague, on your father, mother. This is